Case study number 2, Marissa Henderson, United States University, MSN 570. Sharon Hastings is a 61-year-old female who presented to the office for her follow-up visit. She was started on a new diet to combat her obesity. She complains of being stuck after losing 30 pounds. Last visit was 6 weeks ago, and patient's weight was 315 pounds. Sharon presented today for her follow-up and complained of being stuck and no weight loss in over a week. Patient complains of being tired all the time and not wanting to get out of bed. Patient has a history of hypertension, chronic kidney disease, osteoarthritis, and degenerative disc disease. Her past surgeries include bilateral hip replacement 11 years ago, gallbladder removed in 2005, lap band placed in January 2006. Patient stated that she still has a band, but it was released due to mushrooming of stomach over the band in 2012. Patient has never gone back for a checkup after that. She has a history of breast cancer in her grandmother and hypertension and arthritis in her father. Patient complains of being dizzy when she stands up. Patient is walker bound and cannot lift either legs by herself. Chronic pain in her back and bilateral legs. Patient is currently on verapamil, gabapentin, tramadol, hydrochlorothiazide, and tizanidine. Has lost 30 pounds since the last 6-week visit with diet and no exercise. What can we do to prevent patient from gaining back the weight she lost and continue to lose? Obesity poses one of the biggest challenges facing public health care professionals. The pathophysiology of obesity is complex and involves the interaction of numerous cytokines, hormones, and neurotransmitters. With hormones out of balance, this could lead to excess eating and our body telling us that we are hungry when we are not in need. Adipokines participate in regulation of food intake, lipid storage and metabolism, insulin sensitivity, the alternative complement system, vascular hemostasis, blood pressure regulation, angiogenesis, the inflammatory and immune responses, female reproduction, and regulation of energy metabolism. In the neuroendocrine system, appetite is controlled and BMI. The system is complex and controlled by a dynamic circuit of signaling molecules from the periphery acting on central controls, including the brainstem, hypothalamus, and autonomic nervous system. With this imbalance, a patient could see an increase in hunger and they could possibly eat more than they really want to, which ultimately leads to obesity. Hormones that are affected include ghrelin, peptide YY, cholecystokine, GLP-1, insulin, leptin, adiponectin, RBP4, and endocannabinoids. Obesity results from a chronic imbalance between energy intake and energy expenditure, leading to storage of excess energy as fat, primarily in white adipose tissue. We as providers can tell the patients to eat well and exercise, but what is to say that they will actually do it? What keeps them from doing it sometimes? Patients struggle because of problems with appetite and metabolic adaptations to weight loss. So while patients' bodies are trying to regulate, the patient can still feel hungry all the time and never satisfied. We need to make sure that we are controlling their appetite too. How do we assess obesity in patients? There are several factors that go along with this. For practical purposes, BMI is a reasonable surrogate measure of total body fat and should be measured annually or more frequently. Sharon's current BMI is 48.9. A waist circumference greater than 35 inches in women and greater than 40 inches in men is considered a cardiovascular risk factor. Sharon's current waist circumference is 49 inches as of this recent visit. It was 51.5 inches at the first visit to the doctor 6 weeks ago. Additional risk factors include elevated blood pressure, lipids, and glucose, as well as established atherosclerotic disease and sleep apnea. When our patient comes in, we want to know why they are here and want to lose weight. With Sharon, it was not really her choice as her health is getting worse, and without fixing her current weight and health, she is at risk for death at a younger age. Determination should also be made of past weight loss attempts, treatments utilized, and reasons and barriers for success or failure. Sharon suffers from chronic kidney disease. Chronic kidney disease is the progressive loss of renal function associated with systemic diseases such as hypertension, diabetes mellitus, systemic lupus erythematosus, or intrinsic kidney disease, including kidney stones, acute kidney injury, chronic glomerulonephritis, chronic pyelonephritis, obstructive uropathies, or vascular disorders. Sharon stated that she had several kidney stones as a child and has always struggled to drink enough water since she was a child. She loves to drink soda and sweet tea. The kidneys have a remarkable ability to adapt to loss of nephron mass. Symptomatic changes resulting from increased levels of creatinine, urea, and potassium and alterations in salt and water balance usually do not become apparent until renal function declines to less than 25% of normal when adaptive renal reserves have been exhausted. Sharon has always had issues with her kidneys, but did not get diagnosed with chronic kidney disease till about 2 years ago. The factors that contribute to the pathogenesis of CKD are complex and involve the interaction of many cells, cytokines, and structural alterations. Cytokines are also part of the pathophysiology of obesity, so these two could be factors of each other's. Glomerular hyperfiltration and increased glomerular capillary permeability lead to proteinuria. Proteinuria contributes to tubulointerstitial injury by accumulating in the interstitial space and activating complement proteins and other mediators in cells, such as macrophages, that promote inflammation and progressive fibrosis. Hypertension is caused by increase in cardiac output or total peripheral resistance, or both. Sharon has had hypertension for 9 years. Cardiac output is increased by any condition that increases heart rate or stroke volume, whereas peripheral resistance is increased by any factor that increases blood viscosity or reduced vessel diameter, also known as vasoconstriction. Inflammation, endothelial dysfunction, obesity-related hormones, and insulin resistance also contribute to both increased peripheral and increased blood volume. Hormones from obesity could be affecting her blood pressures. Increased vascular volume is related to a decrease in renal excretion of salt, often referred to as a shift in the pressure-natriuresis relationship. Men and women are affected equally. However, women report low back pain symptoms more often after the age of 60 years. Sharon did not have chronic back pain until the past 3 years. She had never had issues with it before this point in time. There have been several risk factors associated with back pain. They include involvement caused by occupations that require repetitive lifting in the forward bend and twist position, exposure to vibrations caused by vehicles or industrial machinery, psychosocial workplace factors, and obesity. Sharon has been obese on and off for her entire life. Local processes may be involved in low back pain, including tension caused by tumors or disc prolapse, bursitis, synovitis, rising venous and tissue pressures found in degenerative joint disease, abnormal bone pressures, problems with spinal mobility, inflammation caused by infection, as in osteomyelitis, bone fractures, ligamentous sprains, and inflammation of the lumbar facet joints. Sharon has had low back pain for several years, which leads to the next comorbidity, which is degenerative disc disease. Sharon also suffers from degenerative disc disease. Degenerative disc disease, also known as DDD, is common findings in individuals 30 years of age and older. It is, in part, a process of normal aging and includes a genetic component and environmental interactions that may increase susceptibility to lumbar disc disease by disrupting normal building and maintenance of cartilage. It is a part of normal aging, but the disc can wear down easier with obesity. Causes include biochemical and biomechanical alterations of the intervertebral disc tissues. Osteoarthritis is a common age-related disorder of synovial joints. It is characterized by local areas of loss and damage of articular cartilage, new bone formation of joint margins, subchondral bone changes, variable degrees of mild synovitis, and thickening of the joint capsule. Sharon tends to have the worst time with her knees and hips. The exact cause of OA is uncertain. However, pathology centers on load-bearing areas. Sharon is currently on verapamil, gabapentin, tramadol, hydrochlorothiazide, and tizanidine. Verapamil is a calcium channel blocking drug. The major effect of these medications is to decrease the strength of the cardiac contraction. This is used for her hypertension. Gabapentin is being used for nerve pain from her degenerative disc disease. The discs are pressing on nerves and causing Sharon nerve pain. Tramadol as a pain medication is being used to help with the chronic back pain. Hydrochlorothiazide is used to help with Sharon's hypertension and help her body to excrete extra salt since her kidneys do not function like a normal kidney should. This is a diuretic. Last is tizanidine. It is a muscle relaxer. It is used for Sharon to help with her back pain that is associated with the degenerative disc disease. There is more than one way to eat healthfully, and everyone has their own eating style. Make healthier choices that reflect your preferences, culture, traditions, and budget. Choose fruits, vegetables, grains, dairy, and protein foods to get the most nutrition and meet your personal calorie needs. Aim for a variety of foods and beverages from each food group and limited saturated fat, sodium, and added sugars. Whatever you eat matters. That means even if it's only a small amount of food, we need to watch what we are putting into our bodies. We want to find those foods that are less sodium and no added sugars. Lastly, always start small. Sometimes with drastic changes, it is difficult to stick with a diet/lifestyle change. Obesity-related cardiovascular and metabolic disease is particularly linked to increased visceral adipose tissue and intrahepatic lipid. Exercise is crucial for the obese patient. It is going to be different for all patients depending on their physical abilities and other medical factors. Pharmacological agents do not reduce fat specifically from these regions or are unsuitable for long-term management. Therefore, establishing an efficacy of lifestyle therapies, including exercise, is increasingly important for the management of obesity and related comorbidities. Whether this is being done for Sharon or any other obesity patient, it needs to fit their lifestyle and needs, or they are less likely to actually partake in it. Exercise guidelines for health and fitness promote the use of both regular aerobic and resistance training. Based on the findings from this study, we recommend that a sufficient volume of aerobic exercise should be principally promoted for the reduction of liver fat and visceral adipose tissue. Obesity is a chronic disease for which various treatment approaches have been used, including correction of metabolic abnormalities, individually tailored weight reduction diets, and exercise programs. Exercise guidelines for health and fitness promote the use of both regular aerobic and resistance training. We are going to start with water aerobics in Sharon's pool since she is struggling to walk, and the pool water takes away most pressure on the joints. We are also going to focus on a new diet for Sharon, which is a lower carb diet with elimination of all sugary drinks. She can have dark coffee and water. We are going to continue her with the medication she is on. We're not going to change any of them up. We will be adding Zoloft for depression and have a consult in for Sharon to begin counseling. She states she is always tired and feels down all the time. Last but not least, we are going to build on what Sharon already knows, but educate her on what she does not know about her current plans, her medications, and any questions she might have. Sharon will return to us in 4 weeks for a checkup of the new medication and to see if the weight loss has increased since this visit. Thank you so much.